Okay, so welcome to this little mini lecture series. Basically, what we're going to be doing is just going over Wendover ambulances advanced EMT protocols that deviate from the National Registry. So like I said, this is going to be focused on AEMTs and their scopes, and specifically what at least I personally did not learn in the NREMT advanced course. So here are all the topics that we're going to go over. It is really just we're going to go line by line or page by page based on the actual protocols that you're going to have on the ambulance. If you want to take a second, pause, write these out or something, or kind of get an idea, feel free, but we're going to go ahead and move on. Okay, so here are a few things that I want you to keep in mind whenever we're going through the protocols. So first off, almost every protocol recommends that we initiate cardiac monitoring, and almost every protocol permits the implementation of these three. Actually, let me really fast. I am going to change the size of the pen. We're going to do this. Okay, there we go. Is that better? Okay, that's a little bit better. Alrighty, so almost every single protocol permits or even recommends, requires the use of cardiac monitoring, ETCO2, and pulse oximetry. So for the cardiac monitoring, we're not paramedics. Make sure we send those into the hospital if there's any kind of cardiac related issue that we think is going in. As for ETCO2, you may not have covered that very extensively in your advanced course, and we're not going to cover that here. So make sure you kind of go brush up on, like, how do I read waveforms? Like, what is a proper? Is this normal? Is this normal? Let's make sure, like, you know what the waveforms are supposed to look like and what the ranges are, what that means for your treatment. Med control. So whenever we usually transport, we're going to want to call medical control before we even leave Wendover. Just kind of run by them what our patient is presenting with, their specifics, and then what is our treatment plan, and then any kind of questions you might have, and then end it with the ETA. So if you've ever heard of something called MIST, we'll just move that over here. MIST is an acronym that the University of Utah likes for us to use, and it stands for Mechanism Give me 1 second, and I will, because I don't actually remember the I always confuse it with interventions. I'm pretty sure it's like injuries and illness or something like that. Yeah, injuries and illness. Illness. I'll write a manuscript so you guys can read it. And then S is signs. So that includes your vitals. Oh, this is so ugly. Symptoms. History. Significant history. So, if you're transporting a cardiac patient and they have, you're transporting, let's say, somebody who has like an obvious STEMI and they have chest pain and they're a male and they have, pain in the radius down their left side, and there's, a history of cardiovascular issues. Tell them that history, but you don't need to tell them that when they were 15 they had an appendectomy, right? So significant history. And then finally, your interventions or treatments. Oops, that goes under T. Treatments. All right. So, and then lastly, ETA for the communication with medical control. Generally, your ETA to University of Utah is going to be 2 hours. Even if it says 1 hour, 1 hour and 40 minutes on the phone, just say for 2 hours. So try to call medical control before you get too far into your transport to make sure that they're on board with it. I put an asterisk by things that are in the new protocols. So if you know that the 2020 protocols with Wendover have been implemented, then you can go ahead and refer to that, to the things I talk about that have this yellow asterisk, okay? If it doesn't have the yellow asterisk, that's the old protocols, or that's like the protocols that are going to be true regardless of the time, right? Regardless whether it's whether we've implemented 2020 protocols or not. And then lastly, always remember, your basics, the protocols. Every single one of them wants you to go through your ABCDs, and it wants to go through a primary assessment. Okay, so just want to kind of like explain those or get those out of the way before we get started. So, and I'm going to once again make my pointer a little bit bigger because I don't like how small it is. We're gonna go here. Okay, so let's start off with the general guidelines. So airway and tracheostomy management, don't get a whole lot of these, but if you do, you want to make sure that you know what you're doing. So this is covering for both EMTs and advanced EMTs. Whenever you go on these kind of scenes, make sure that if there's any kind of CNAs, if there's any kind of nurses, or there's any kind of caregivers that are there, ask them for help, and refer to them for any kind of questions you have, and they're going to be the best support you're going to be able to get.
If the patient is apneic, if they're unresponsive, if they're in respiratory distress, just like you would with a regular patient that does not have a tracheostomy, go ahead and apply BVM and manually ventilate. And then, if you need to, if it's necessary, you are also permitted to suction. They give us this mnemonic that they recommend that we use to help assess the tracheostomy of tracheostomy patients, and that's called DOPE. As you can tell, it's dislodged, obstructed pneumothorax, and equipment failure. So this is obviously just kind of things I guess they want us to look for whenever there's a patient who's in respiratory distress and who has a tracheostomy present. Let's move on. Oh, I think it froze me. Yeah, it did. Let's try this. Oh, what is it doing? Ah, there we go. Okay, sorry that. Okay, and then for advanced EMTs, if you're unable to manually ventilate with a BVM, you can go and go to a supraglottic if necessary. And then also, advanced EMTs are permitted to apply CPAP on these patients, and just use the same criteria that you would for other patients when applying and determining whether or not CPAP is necessary, as you would with the tracheostomy, right? So we're looking at any kind of patients that are experiencing CHF, pulmonary edema. It's not very pretty. And then also, just like any other patient, like make sure you coach them through it.
Okay, let's go ahead and move on to altered status. And the one thing I wanted to discuss is the administration of naloxone as a general rule of thumb, but also as part of our protocols. If somebody is altered and you can't find a cause for it, they appear to have no other issues, no other reasons for this, administer naloxone. Unless, of course, you are certain that there is no opiate involvement, go ahead and do that as a precautionary measure. And that's going to be the same dosage that you learned for us. For your NREMT, it's going to be the same dosage for us. Now, does anybody know what the pediatric dosage is? Go ahead and throw out a number, write it down, something if you know. If you don't know, pick a guess, and then come back to the video. Alrighty, so, and hopefully I'll try to make this as engaging as possible throughout with questions like this about dosages and about, what you might think, but I can only be so engaging in the video. And the answer was 0.1 milligram per kilogram for pediatric naloxone administration. Now let's go to move on to termination of resuscitation and determining death. We are permitted to just not even start resuscitation whenever there are a few criteria present according to the protocols. And then obviously, as we'll see later, we're allowed to consult online medical control, so medical control, and terminate resuscitation in other situations that may not follow these protocols. But the first one is going to be injuries that are incompatible with life. That's going to be decomposition. Ooh, I misspelled that. That's okay. Decomposition, rigor mortis. And even if you've never seen this, it'll be really obvious what you're looking at. If you've never seen rigor mortis, it'll be very, very obvious that somebody is in rigor mortis. So fatal wounds, such as, oh my lord, amputations, decapitations, etc. And then lastly, it's going to be lividity. If you don't remember what that means, go look it up and then come back and tell myself or Darren. You can be proud of that. And then for adults, there's a special set of criteria that we can implement. Once again, though, you can always call medical control. But if it's an adult patient who is apneic, who is pulseless, and who has asystole, so you got to get them up on that cardiac monitor and see this that they're asystolic. Let's say 32%, right? And then if they have all of this and one of these criteria here, A, B, or C and D and E, which I'll kind of like briefly mention a little bit, but specifically the A and B are going to be where we're going to see them most. If one of these are present with 1, 2, and 3, then we can terminate or not even start resuscitation. So if the patient had an unwitnessed arrest an unwitnessed arrest that occurred 15 minutes prior to the initiation of CPR, we can go ahead and terminate that. If it was a traumatic arrest and there's no additional signs of life, we can go ahead and stop those as well. And the other situations include, if we're in a resource limited environment, right? So if this is a mass casualty, if this was a submersion incident or arrest, we don't have to start those. And okay, yeah, that's going to be those other situations. As for no signs of life, what we're referring to is a few criteria that honestly you should always do on patients that are in cardiac arrest and you want to confirm their death. And that's going to be pupillary reflexes. Any kind of looking for any kind of movement, which is kind of obvious, but then checking for pain response, checking for pain response, and then looking for organized electrical activity. So we'll just label that as we'll do electrical activity. These are all, if there's no pupillary reflexes, this is going to be negative. If there's no pain response and there's no electrical activity, then those are all signs of death, right? So then if one of them are positive, then that's signs that there might be life. So for the DNR, those are the do not resuscitate orders. They can either be written or they can be verbal. They can be in the form of a bracelet, they can be in the form of a necklace, or they can be in the form of like an actual like order. There's also sometimes something called POLSTs, which stand for Provider Order for Life-Sustaining Treatment, and those will just outline what the patient has already requested or determined or desired be their life-saving treatment, and we need to follow those. These do not resuscitate orders / life-sustaining treatment orders can also be at family members' requests, and for us to like follow their request, we need to ensure that the patient had a chronic or terminal illness that may have caused this, and all relatives on the scene, as well as EMS providers and online medical control, all need to be in agreement before we terminate resuscitation in spite of signs of life. So let me kind of explain that again. So for us to comply with family member requests to not resuscitate per the protocols, all family members need to agree that are on scene. I know this is kind of excessive, but it's it's important to know our protocols and know this stuff. EMS providers all have to agree that are on scene. And then also online medical control needs to be brought in and informed of the situation. So this would occur if there's somebody who, like I said, has, let's say they have electrical activity, but they don't respond to pain, they don't respond to pupillary like reactions, they don't have any kind of pupillary reaction, and we just got on scene. We're initiating ACLS, and the family says, "Hey, this person had terminal cancer, and we really don't want to continue with this. They're not gonna come back." And then all the family members agree, we don't want to continue with this. And then all the EMS providers on scene need to be in somewhat of a, they need to be in agreement that, okay, this is acceptable, this is understandable, and then we need to call online medical control, and that would stop us. We can terminate resuscitation or not even start it if we go through that process. And that would just be, to keep the integrity, the respect of the person who passed away. And then terminating CPR while it's already in progress. We're going to always want to be in consultation with online medical control. And if the above criteria that we kind of went through, that I kind of mentioned already, terminating CPR, so all of this, injuries that are incompatible with life, and if adults that comply with these rules right here, these 1, 2, 3, or A and B, if those are all present and CPR has already been started, we're allowed to terminate, even if fire has already started or law enforcement has already started compressions. And then the other thing we can do is if resuscitation has been ongoing for 20 minutes, and it needs to be 20 minutes of, according to protocols, ACLS. And it was an unwitnessed arrest, and there was no shockable rhythm at any time, and there has not been ROSC at any point. Then we can also terminate at that point with medical control's approval according to our protocols. And then as for pediatrics, what are they recommending? They're just recommending that we transport after 15 minutes, and unless it's obvious signs of death above that we kind of mentioned. But transport them after 15 minutes, regardless of regardless of electrical activity, or even of like prognosis. So like transport those within 15 minutes. And the resuscitation should be carried out en route. Now, I want to preface, I've just gone through the protocols, what our protocols state, and although these are our protocols and they were approved by our physician, they're really designed for inner city or at least EMS agencies that are close to a hospital, that are within 15, 20 minutes from a hospital, 30 minutes, and they can transport these patients. There's they can get these cardiac arrest patients to ECMO sooner, et cetera, et cetera. But with us, as you know, we're 2 hours away from the hospital. So a lot of times we're going to call medical control, and regardless of whether or not it was let's say it was a witnessed arrest, and let's say that there have been shockable rhythms, but let's say we've been resuscitating with ACLS for 20 minutes, 30 minutes, and there's no ROSC, we're going to probably call medical control and ask to request to terminate resuscitation, because we're 2 hours from the hospital. We can't really transport for 2 hours while we're in the middle of performing compressions. It's not safe. So these are our protocols. They're useful for not even starting resuscitation when these criteria are present, which a lot of times law enforcement will kind of make the decision for us before we even arrive on scene. But other than that, really contact medical control, and you'll probably have somebody there with you who's going to be able to guide you through this. Alrighty, so let's go ahead and move on to nausea and vomiting. And the two things I wanted to really discuss in this section is promethazine, which is a medication that a lot of people probably are not familiar with, and Zofran for peds. Now, although we're going to go over all the pediatric dosages in these protocols, I really recommend that before you administer medications to pediatrics, to children, just look at the protocol, check out the dosage, because we don't do it frequently enough to be experts at it. And also, especially if you're administering ACLS medications, we're going to make that, get rid of that arrow. If you are administering ACLS medications, look at the PD tape. This long piece of tape or paper that has dosages based on a kid's height, and that will tell you, what doses to give them based on their height, and you don't have to guess how much do they weigh, and it's less prone to error. Now let's go to promethazine. Promethazine is a really cool drug. If you know what it is, awesome. I forgot to erase the adult dosage there. Oh well. There you can see the adult dosage, and we'll discuss that in a little bit. But the important part about promethazine is that A, it's an antiemetic. If you don't remember what that means, go look it up. You should definitely know what an antiemetic means, though. It is also a sedative, and it's an anesthetic. The important thing for our protocols is this one right here. As you'll get through and gain more experience, you'll learn that these two can go really well whenever you're managing pain without a paramedic. But for right now, let's discuss the antiemetic properties. So it can reduce nausea and it can stop vomiting whenever the patient is actively vomiting. But the really interesting and important thing to keep in mind with promethazine, in addition to the sedation properties and the synergism with other sedatives and analgesics, in addition to that, the other important thing is that it can cause necrosis if it leaks out into the interstitial space. We'll draw a little vein here. If it leaks out, it can cause bad necrosis if it gets into the interstitial space, just like dextrose does. So obviously some of the adverse side effects of promethazine administration is going to be like gangrene, severe tissue injury. So that being said, that doesn't stop us from administering it, but that just changes, the precautions that we take when administering, which you should always, make sure that for example, your line's patent before you administer medication. But we're going to take some extra precautions with promethazine. Now, just because it can cause, I want to repeat again, just because it can cause this severe, serious injury, doesn't mean you should not administer it, right? It just means to be cautious. Now, the adult dose is going to be 12.5 to 25 milligrams. I personally like to do 12.5, especially if the patient has other things on board that we're administering. So, example for administering an analgesic such as Nubane, which we'll kind of briefly mention, or if they've taken, opiates or other recreational, we'll call them downers, other recreational depressants. Really be careful administering this promethazine if you really want to administer promethazine, because it's a sedative, right? So synergism right there, and you're going to want to watch for any kind of respiratory depression that might occur. So try to go with smaller dosages if you can. 12.5 is the protocol's recommended lowest dose, and they come in 25 milligram vials. For pediatrics, can you guess what the pediatric dosage is? It's not recommended. Exactly. Yes, it's a trick question. It's not recommended for pediatrics. If they're over 2 years old, we can give it to them. That's okay. but it's still not recommended. Probably should call medical control before you want to give it, just to make sure you don't go into the ER and get yelled at. But the dosage, if you are going to give it, is going to be 1 milligram per kilogram. Oops, I'm so sorry. That K is very ugly. 1 milligram per kilogram. And for these pediatric dosages, obviously, if the patient is, if they're in the pubescent stage or period of development, you can probably go with the adult dosage. Or if the pediatric dosage supersedes or goes above the adult dose, you can stop. So, for example, let's say the kid is 40 kilograms. That's a pretty big kid. So we'll do, let's say they're a 20 kilogram kid. You're at 20 milligrams right there, and they're only 20 kilograms. So I would just go down to the 12.5 milligram dose if I had to administer promethazine. If they're less than 2 years of age, we're not supposed to administer to them. The issue being that, and we'll kind of briefly mention the adverse side effects over here in a second. I'll list them out, even though we kind of already discussed it a little bit. But for 2 years of age and younger, there's a higher risk for respiratory, I believe. Yeah, respiratory. Oh, it says compromise, but oops, I just spelled respiratory wrong. Respiratory compromise. Other adverse side effects to keep in mind is anything that will be related to a sedative or sedation medication. So drowsiness, confusion, especially in geriatrics. I'll kind of mention that. I'll talk about that in a little bit. Give you a little bit of an anecdote. Vertigo, dizziness, and then obviously respiratory depression. So this is kind of also the stuff you should be monitoring whenever you're transporting a patient who you're giving a lot of promethazine to. First off, if they become drowsy, let them know that's normal. That's a side effect of the promethazine. And maybe even tell them ahead of time, like, hey, I'm going to give you this medication, and you're going to get drowsy because of it. Don't get afraid. And then in geriatrics, be really careful administering this to older people, because it really will cause them to kind of go wonky. They'll almost start acting like they're sundowning. It's kind of weird. Vertigo and dizziness, just because it has that anesthetic and sedative property, and then respiratory depression. So make sure you're monitoring the respiration. Just, if they do fall asleep, which is totally fine, you don't have to wake them up. Just watch their respirations. Make sure they have that good chest rise, chest fall. And then for administration, we want to first off dilute whenever we administer the medication. We want to administer it in an IV above the wrist, and we want to do a large vessel. So usually the way we can determine that it's a large vessel is that you want to administer it in an IV that is larger than a 20 gauge, so a 16, a 14, so a 14, a 16, and an 18. Above the wrist, pretty self-explanatory. They don't want us administering it below the wrist. Dilution, what you can do is you can use a 10 cc, ooh, that's my syringe. So this is 10 cc's right here. Use a 10 cc syringe and the vial kind of looks like this because you got to crack it open. Oops. Oh, I'm sorry, I'm thinking of Nubane. So the vial looks like a regular vial. There's a vial. So what you can do is you can get a 10 cc flush, push out a half cc, so 1/2 of a cc, and then draw up a half cc of promethazine, because it comes in 1 milliliter per 25 milligrams. That may not be the best dosaging. So another possibility is to remove all of the, or get a clean 10 cc syringe, draw up 1/2, make sure that it's the proper amount in the empty syringe, and then go over to your IV line, and then draw out saline from that line from the bag. And that way you have a diluted administration of promethazine, and then whenever you administer it, you continue to dilute it by either flushing and opening the line wide open, or just leaving it wide open. Now you can, just like with everything else, if you need to give promethazine and all you can get is a 20 gauge in, let's say, right around the wrist, let's say like, if this is the person's hand, that's, oh, perfect. This is the person's hand, right? And you have a 20 gauge right there. Oops, that's a little bit too high. You have a 20 gauge right there. All right. Call medical control. Tell them your situation. Tell them, like, either you need to do it, or because you're out of Zofran, or et cetera, and they can give you the permission and the A-OK go ahead to administer that promethazine. So for Zofran, our pediatric dosage is going to be 0.1 milligram per kilogram. Same rules, same protocols that you would do with NREMT. Do the same with for us. Okay, so let's go ahead and start on pain and anxiety management. In general, we're going to administer analgesics until the patient's pain is relieved. Obviously, we want to monitor their respiratory drive and their blood pressure. Make sure that we don't dip below a systolic of 100 and a systolic of 70 in pediatrics. If we do, go ahead and stop administration, and then go and follow our shock protocols, which will probably recommend. I don't believe it's I don't know if it's. I think it's a systolic of 100 that we start. Maybe it's 90, and we'll give boluses just to make sure that it doesn't drop any further. Also, be cognizant of any kind of synergism with their medications or drugs that they're on, and also alcohol that they've consumed. Don't forget, this is a casino town, so lots of people are going to be, lots of out-of-towners are going to be drinking during the day. And if we're going to administer, let's say the patient has nausea and you give them promethazine, and then they all of a sudden start having abdominal pain because of all the vomiting that they've been doing, make sure that you're aware and that you are cognizant and monitor the respiratory rate, monitor their mental status while you give, let's say, Nubane on top of the promethazine. A lot of these medications that we're going to give, they cause nausea. And in the back of an ambulance, if you've ever been, it can be pretty chaotic with all the movement. So consider prophylactic anti-emesis or antiemetics. My go-to is always Zofran. I honestly give Zofran to patients, just leaving Wendover a lot of times, because I personally get sick in the back of the ambulance, and I am moving around, able to kind of, like, air myself out, and they're stuck on the cot just getting bounced around. So feel free to administer the Zofran liberally, because you don't want to have uncomfortable patients for 2 hours. Now, here are our medications for pain. This is a pretty cool one right here. This one is, right now, it's pretty consistent through all of our protocols, and that's going to be Nubane. Nubane is pretty standard line for us. It's an interesting medication because it is a opiate agonist and antagonist. Now, unlike what people say, Nubane works. It does a really good job. It does a wonderful job, and it I don't remember exactly the proper pharmacokinetic or pharmacological way of saying this, but basically it'll tap itself out. So there's the the GABA receptors that it binds to and blocks will only be affected by so much Nubane, and then eventually it won't be stimulated or be blocked any further. So after about 10 milligrams of Nubane, I'm pretty sure studies have shown that any more than that, and you're just kind of like, you know, pissing into the wind. So, which should, you know, obviously, I'm trying to inform you that, just to let you know that's part of the reason why Nubane doesn't really cause respiratory depression by itself. Also, the receptors that it binds to aren't connected to aren't as let's say in tune with your respiratory system. So that's also part of the reason why it doesn't have the same side effects as like morphine or fentanyl. And it's in our medication box. It's in our protocols. If you need to administer it, you know, feel free to administer it. If you're 10 minutes away from a helicopter and the patient's in you know, in 1,000 out of 10 pain, maybe hold off or ask them, like, hey, do you mind if I administer some Nubane? But, you know, don't worry about being afraid that because it's an antagonist of narcotics that you might limit their pain management capabilities. They have ketamine. It's okay. For the ketorolac, once again, a really awesome drug. This is a type of, oh, sorry, acetaminophen is not an NSAID. This is a type of NSAID. So I don't know if it's a selective or unselective or I guess, yeah, unselective COX inhibitor, but it's just a type of NSAID. Once again, it's super cool. It's an IV medication. So I kind of forgot to mention that. So the ketorolac is IV and the Nubane is IV. Promethazine and Zofran obviously are IV as well. Ibuprofen and acetaminophen, those are both PO. Forgot to mention that. But with the ketorolac, we're going to be administering that for pretty isolated injuries. So if somebody strained their ankle, or I'm sorry, sprained their ankle, or you know, they have the really common administration of, or the use of ketorolac is going to be kidney stones. So nephrolithiasis. Oops, I'm so sorry that. Also migraines. But for those kind of isolated injuries or illnesses, it does a really great job. And I honestly have never administered ibuprofen or acetaminophen as pain management on the ambulances, probably because these are kind of new. But, you know, whatever floats your boat, and if you think it's going to work and you think that there's no contraindications present, I would go with acetaminophen if you really have to, and if medical control is like, yeah, totally, let's do it. Acetaminophen is really awesome. It doesn't have a cap like ibuprofen does, which, you know, after 800 milligrams doesn't really do anything. And you know, there's really great studies that show that it does an awesome job at reducing pain. Once again, these are both PO, which means per os, right? So it's going to be oral. Nubane can also be administered not only through IV, but also IO and IM. So really versatile drug. Now, in like level or ranking of administration, you're going to want to administer, you know, Nubane first. That should always be your first line. And then if, like I said, you have an isolated pain, go for that ketorolac. And if for some reason, I don't know, I'm not really sure why you would administer the acetaminophen and ibuprofen, but if that is, go with that acetaminophen first and then ibuprofen. So for the adult dose of acetaminophen, and drum roll please, 650 to 1,000. I always go with 1,000 if in my personal life and with what I've read through studies. Ibuprofen is going to be that 600 milligrams, and ketorolac we're going to be administering 15. So kind of keep this in mind. And then Nubane is 10 milligrams. if I have a patient who has like minor pain and like we have a frequent flyer this is I just actually went on this, and they have minor pains and they are nauseous. I'm going to give 12.5 of Promethazine and 5 of Nubane, because I don't want to cause respiratory depression or any other kind of, and especially depending on how much promethazine we have on board. If we only have 12.5 on, we'll go straight for the 10. But if not, and if we have like maybe already at this point 50 or 62.5, I guess actually it would be 50 or like 25 milligrams of promethazine on board, then I'll go with the 5 milligrams of Nubane. Ketorolac is going to be a single dose, as well as the ibuprofen and acetaminophen, whereas this Nubane we can do every 10 minutes. Now remember, we are trying to, I didn't write it up here, we're trying to administer the analgesic, we'll write it over here, until the pain subsides or is manageable. So, if 10 milligrams of Nubane does it, you don't need to administer another 10 milligrams. Obviously, these NSAIDs and the acetaminophen are single doses, so no issue there. With the pediatric dose for acetaminophen, we're looking at 15 milligrams per kilogram. Ibuprofen is 10 milligrams per kilogram. Ketorolac is 0.5 and milligrams per kilogram. Nubane is not indicated, not recommended. So keep that in mind with kids. Call medical control and make sure that if you're the only, let's say there's no paramedic unit, you can't rendezvous with Mountain West, and this isn't very serious enough to contact Life Flight, but you want to give analgesics, contact to a child, contact medical control. As for the ibuprofen, we want to give it in kids that are older than 6 months. And for the Ketorolac, we want to give it to children that are older than 2 years of age. Now, let's go into our anxiety control. We administer, we haven't incorporated lorazepam yet, also known as Ativan. I just spelled that wrong. I'm so sorry. But we haven't incorporated lorazepam yet into our protocols. So I usually administer midazolam, or also known as Versed, and these are both just benzodiazepines that we use to if someone has anxiety, if we need to have chemical sedation, or Ativan, I've been told can be, well, actually we'll skip that. We'll cut that out of there. But mainly for chemical sedation and anxiety, we administer midazolam. The adult dose we're looking at, it comes in 5 milligram vials. So adult dose is going to be 2.5 to 5 milligrams. Q 10 minutes. And it can be administered IV, IO. Oh, sorry, not IO. My bad. Or intramuscularly. Lorazepam, same method of administration, but we're going to be doing 2 milligrams and Q 5 minutes. And for administration via IM, because we're going to have to kind of go through basically, like we have to go through, it's going to take a longer period of time, and there's going to be more metabolism and more barriers to access the the vasculature for midazolam IM. Let me just make sure I got this right because this is kind of a lot. We're going to be administering 10 milligrams at one time for IM midazolam. Now, for IM lorazepam, it's going to be 4 milligrams. Now, these benzodiazepines or benzos, we call it chemical sedation for a reason because these are sedatives. They're not only anxiolytics, but they're also sedatives. So they can cause respiratory depression, they cause drowsiness, everything that the promethazine does, they can cause it. So make sure that you're watching for any kind of synergism if you have promethazine on board, but also max dosages. I think it's a 10 milligram max for, 10 milligram max for Versed and a 4 milligram max for lorazepam. Obviously, if we got to administer more than that, contact medical control. And then I want to just really fast do pediatrics. Peds for midazolam is going to be 0.1 milligram per kilogram IV. And then for Ativan, oh no, I was going to do this, isn't it? Oh, goodness. For Ativan, it's going to be 0.05 mgs per kg IV. And if you haven't caught on yet, for IM, at least for the Versed, for the Ativan, we're going to administer the same dosage. But for the IM, it's going to be just 2 times IV dosage. So 0.2 mg per kg. Don't we love math? Alrighty, so next up is going to be shock and sepsis and then fluid therapy. Once again, though, I want to reiterate. If you got to administer more than what the protocols say or change something in here, contact medical control. They'll always be super helpful. Alrighty, so let's go ahead and dive into sepsis. Oops, I kind of forgot to erase my previous notes. We'll go ahead and dive right into sepsis. Now, like I kind of mentioned, these protocols were designed for agencies that are close to a hospital, and they're meant for all of Utah. But as you know, we're not really close to a hospital. So, the sepsis alert, that kind of, it doesn't really apply to us because we rarely ever take in patients that are this critical directly to a hospital because we try to either fly them out or with a fixed wing or with a rotary, like a helicopter. And if you can't get a helicopter, then it might even be best just to wait the 20 minutes at the airport in Wendover, especially if a patient has these issues, right? This criteria is positive for an infection, and they have a low blood pressure and a low EtCO2. That's a really serious and sick patient. They need to be given antibiotics immediately, and they need to be rapidly perfused, which we can give them some fluid therapy. But I think that it's a good tidbit to know the criteria for sepsis, because although you should have alarm bells, ringing and off the hook if you see a patient that has this criteria, regardless of the criteria. If you see a patient that has this stuff, you should be like, oh my gosh, that's this is not good. But it's just nice to know the criteria. So to start off, if a patient has the presence of an infection, so if there's an infection present, it doesn't need to be a visible infection like gangrene or some sort of necrosis, right? It can be an influenza, which usually is going to present as pneumonia. Oh my gosh, my spelling is awful, guys. I'm so sorry. Those are the common ones, right? Or it can be other kinds of infectious diseases. So meningitis, If you have meningitis, just run out of there. Don't even stay there. Just call the day off. I'm just kidding. You can't do that. But if there's a presence of some sort of infection, oops, sorry, that's my my Spotify. There we go. It got off there. And either two of these are present, so two of these are present, or this is present. Basically, this B is indicating hypoperfusion. So if they are hypoperfusion, there we go. Hypoperfusion. So if these are present, two of these right here, two of A are present, or if they are showing evidence of hypoperfusion, that counts as sepsis. And so we're going to just go through this really fast. If they have a temperature above 104 or less than 96.8, that is considered they're feverish. I don't think that 100.4 is hyperpyrexia. I'm pretty sure that's 104 something. But this is technically what a fever is anything above 100.4. If they are breathing quickly, or if they have a heart rate greater than 90, so note here 90, not 100, but nope, 90. As you'll learn throughout, gaining more experience and learning more, 90 beats per minute is kind of becoming this more the new max, if you will. So we were taught 100. Well, they're kind of going towards 90. So if two of these are present, that counts as sepsis for a sepsis alert. Give them a helicopter. Or if they have a MAP less than 65, or a systolic blood pressure less than 90, or an ATCO2 less than 25, those are all indicators of hypoperfusion. Sorry. Those all count as sepsis alert criteria. And with sepsis, one of the things we're going to want to do is treat shock. Treat shock with fluid therapy. So now that's going to be under. I put it on. I kind of drew that arrow to traumatic shock, but nope, it's going to be under non-traumatic shock. And we're going to go ahead and jump into traumatic shock, which is specifically geared at AEMTs. And let's start off with kind of probably veering away from what we were taught in NREMT, which is something called permissive hypotension. If they don't need to have a systolic of 100, especially if they have a traumatic shock, we can work with a systolic of 80 and a systolic of 90. If I think that the difference between treating or administering fluid boluses with a systolic of 90 versus treating with fluid boluses at a systolic of 80 is going to be the other factors, right? So use your judgment, your clinical judgment. Are they altered? What is their respiratory rate like? What is their heart rate like? And that can help you judge, do I need to give a fluid bolus at 80 or 90 or 85 or whatever, right? And we're gonna permit this hypotension of 80 millimeters of mercury systolic without closed head injuries. If they have closed head injuries, as you know, we are trying to make sure that the brain is perfusing. This is my head right here, right there, and brain perfusing. That's going to be the carotid, and we have the big brain. We're going to cover the eyes. We want to try to make sure there's good perfusion up there, but the issue is that we know that there's increased intracranial pressure, pushing it all back down, preventing new or replenished blood from entering the cranial cavity, at least in a basic idea. So we're going to increase our permittable blood pressure to 110 to 120 to make sure that if, once again, same kind of criteria for, do I choose 110, do I choose 120 to administer the 500 cc bolus? Just look at their presentation, use your clinical judgment, and make sure that their blood pressure stays above 110, 120. Document why you went with 120 instead of 110, right, for administering that fluid bolus. And we're going to want to administer fluid boluses of 500 cc's at a time. And the protocols don't really offer really great max bolus administration for trauma, but later on in the protocols, and I'm gonna, it kind of mentions this, so we're gonna use this as our guide, which is a 2-liter max. But you should not be getting to a 2-liter max. That's a lot of fluid. I'm pretty sure you have like 5 liters of blood in your body. Let's look it up really fast. Let's look it up. How many liters of blood are in the human body? 5 liters. Wow. Yes, I had to look up caloric just to make sure before I talked about it. I wanted to make sure I was telling you guys the right information. Don't get too upset. So 2 liters is already 2/5 of your entire blood volume. So, even though that's the max that they kind of mention in the protocols, don't administer that much. If you need to be flying this person out. Get a paramedic. Call medical control before you administer over 1,000 liters, which is, so 1,000 liters would be 2 boluses. For children, it is wonky as wonky can be. Their max, their total fluid max is 3 liters. Per kilogram, it's going to be 60 cc's per kg. They want you administering boluses of 20 cc's per kg. And there really is no differentiation between head injury or not, or the presence of head injury. So once again, children, max 60 cc's per kg, or if you reach 3 liters, stop there first. This is the only time that I've ever seen this incongruency, where the children's max is higher than the adult max. But if you go on the protocols and you see what I'm talking about, you'll see that the 2 liters that I'm pulling from is below the trauma protocols. But honestly, I think that it's a good idea to kind of have that 2 liters. I would even administer 3 liters to a kid. Like, holy crap, that's a lot of fluid. I would call medical control before doing that. But just keep that in mind. Go look at it yourself. Be your own judge. Oopsie, sorry about that. Oh no, we just lost it big time. Okay, here we go. We're back. Non-traumatic shock, a little bit different. We're a little bit less concerned about, bleeding out, right? And we're going to administer the same boluses, 500 cc boluses. We're going to have a 2 liter max for adults. For children, it's going to be a little bit different. Kind of, sort of. But we're going to try to hold off. So withhold boluses whenever somebody is in cardiogenic shock, if we can. All right, if we can. Cardiogenic shock, they're kind of including pulmonary edema, CHF, but also this is going to be, I guess congestive heart failure is usually, okay, so this usually does not include, whenever we're talking technically, doesn't include AMIs or, let's say, AFib with uncontrolled ventricular response. We'll just label this as arrhythmias. And I know I'm going to spell arrhythmias wrong too. So, although it is a congestive failure of the heart that usually causes cardiogenic shock in arrhythmias and infarctions, so like myocardial infarctions, it's not technically CHF, but it's still going to be a part of that cardiogenic shock. And try to withhold administration of fluids. And if you do, do small boluses. So I just had a patient where I administered 100 cc boluses at a time. Med control, as I said before, 150. But just be really aware. Let me just really fast review, make sure I didn't miss anything under the general non-traumatic shock. Once again, I want to reiterate, I don't know if I mentioned this, we're administering these boluses, especially for the non-traumatic shock, until we're going to reassess after administration. And the reassessment and this is for actually both traumatic and non-traumatic. For that reassessment, we're really looking for a pulmonary edema, or any other kind of respiratory distress. So what is this going to be? How are we going to assess for that? Auscultate, ETCO2, ask them, do you feel difficulty breathing? Do you feel like you have crap in your lungs? I say that, that gets the point across. Auscultation, if you've ever ridden it in the back of the ambulance, you can't hear crap. Ask your partner to pull over if you're administering fluid in somebody that you're worried about having fluid build up in their lungs. It's okay. The 5-10 minutes that it takes for you to auscultate and catch, what would it be, rails, is way more important than getting to the hospital 10 minutes sooner. And let me just really fast. So the blood pressure that we're trying to keep a minimum of 90 millimeters of mercury, right? So a systolic blood pressure of 90 is going to be our general rule of thumb. So let's go ahead and erase some of this stuff. What actually we'll do is we'll just kind of push this down. So minimum, BP, SPP. So it's generally going to be 90. And a MAP of usually 60 to 70. Obviously 65 is going to be probably the lowest because that's what they kind of mentioned over there. I personally prefer MAP. I think it's a more like broad general picture of the situation. Sorry. But also, unlike with traumatic shock, you can administer boluses as needed depending on the results of your assessment. So if a patient that has 100 over 70, 100 over 50, and they're looking like they're shocky, they are acting like they're shocky, they have shock symptoms of shock, go ahead and feel free to administer a bolus. And then lastly, so for kidney failure, we're going to be administering a max of 1 liter in 500 cc boluses. I'm sorry, my bad. It's not for kidney failure, but for a patient with kidney failure or on dialysis or with kidney issues, so like kidney insufficiency, who have shock. So it's not that have this, but who have this plus shock, probably unrelated. It might be related, but probably unrelated. Actually, it might even be related because a lot of times those dialysis patients, come into us with issues because of their dialysis that they haven't completed. We're going to be administering 500 cc boluses with a max of 1 liter, and then reassessing for signs of shock with each, or signs of reversal of shock. Sorry, with each bolus. And if you reach the max on any one of these, guess what the answer is? You probably know it. I bet you know it. Contact medical control. Alrighty. Now, with children, it's going to be pretty similar to the traumatic. We're going to do a max for non-traumatic shock, max of 60 cc's per kg, or 3 liters total, whichever comes first. For cardiogenic shock, same thing. Try to withhold. Don't know if I spelled that right. I did not spell that right. There's supposed to be another H in there. And then for kids with kidney failure or insufficiency. It's going to be a similar kind of protocol where we're going to max out at 1 liter total, or 20 cc's per kg, whichever comes first. So can you guess what our boluses are going to be? If our max is 20 cc's per kg, and for the adults, if you remember, adults max was 1 liter with 500 cc boluses. The boluses for children is going to be 10 cc's per kilogram, 1/2 of the max. Alrighty, cool. Well, I will see you guys on the cardiac